So we're going to stretch our legs now. I'm going to invite our four invited speakers up. Helen Kelleher, if you want to come up to the front. Steve Allender, Brendan Crotty, and Nick Van Zyl. So Helen and Steve, we've met. I think most of you would know Brendan Crotty, who's our Pro Vice Chancellor at Deakin University, the Faculty of Health, and Dr. Nick Van Zyl is a medical specialist and Director of Medical Services at Hamilton Base Hospital. So the final session is a panel discussion. We want to try and bring everything together. We've assembled this small and highly esteemed panel of experts. What we've asked each of these experts to do is to reflect briefly on their own perspective about what the big questions in rural and regional health are, and particularly for Western Victoria. So, what are the innovations we need to address them? And then we'll finalise the session by opening up to you to ask the panellists their advice. So we might start with Helen, and I think we've given you each 5 minutes, is that right?
I won't take 5 minutes. What we've heard about today is a huge range of innovation. For me, innovation invariably attracts talent and attracts talent and it attracts leaders. So the more innovation that the Alliance does, the more talent is likely to be attracted into it. But the big questions are still about how you're going to capture the information. Some of the studies I've heard, I've kind of thought, yeah, well, previous studies have said that, with no offence, but you know what I mean. We often repeat studies that have been done before. We don't always come up with new data, but I don't think we've got time to do that anymore. We've got to keep on innovating. So the big questions for rural health, I think, are about how you capture data so that you keep building. They're about prediction and modelling and getting to sharing the outcomes that you're finding, whether at the short term or over the longer term. So people are asking big questions. It's not just us that's doing that, and I think it has been inspiring. But now I think it's about scaling up what you're going to do, and there are some issues about doing that in terms of data. It's how you're going to build capacity to do that, how you're going to scope out the technical issues around what it is that you want to do and the specifications for that, specifying that, being really clear about that. What are the skills that are needed to do that? There are people out there who have the skills, but I think they're few and far between. So, but being very clear about who you need to do the work that needs to be done in big data is really critical. And putting that team together, because there's no one person that's going to be able to do it all, obviously. Governance of it will be crucial. And I took notes from when Violet was talking about the data registry. It's exactly the same kind of governance issues that are going to be needed. And then how a data warehouse like that is going to be managed, who has responsibility. And that's going to need to be something over the longer term. We learnt that in Medicare locals, you can have management of something and then the government closes you down. And then what happens? So perhaps it needs to be independent of the PHN, or maybe we actually believe this time that the government's going to leave something in place for the next decade or so. But that needs to be thought about, and there needs to be a contingency plan about what's going to happen. And the lesson from that has been learnt from the Medicare local portal, which is in a difficult position at the moment. And it's resolvable, it's just while it just doesn't have a home at the moment. And then there are all the usual research questions about the security of the portal, ensuring that all data is de-identified, but it also needs to be searchable and so on. So all those usual research questions are there. And finally, there are loads of lessons from big business. Business is using this technology, as Steve's pointed out. I had a conversation with someone over morning tea about or lunch, I think it was actuaries. Of course, actuaries have been using this kind of data for, decades, and they do prediction. All the private health insurance companies are doing it and using it. They're not going to share with us what they're learning. They might subpoena us to find out what we're learning, and they're doing that with apparently with the Cancer Council's data on youth and tobacco at the moment. But nonetheless, there are people out there with those skills in big business, and the modelling is there in big business about how to do it. So I think that's another area where we need to scope out what they're doing and what we can learn from them, and how we can grow this capacity for sharing and learning knowledge and turning it into action.
Thank you. I agree. I think innovations, if we talk about that first, a hashtag, and I'm all about Twitter today because of the big data angle, a hashtag we use a lot is not what but how. We actually know what needs to change in a large number of ways, be that access to treatment, be that availability of services, or be that kids need to eat healthier food and be more active. We know the what, but we don't necessarily know the how. I think the innovations need to point to understanding the complexity of why simple single interventions don't work to change that, and how we use that complexity to push back. I'm really pleased to hear Josh talk about that a little bit, and I talked a little bit about that too. One of the mistakes I think we've made in the past badly, and I think it's an innovation for the future, is a way that's engaged. And people say policy, research, practice as if it's easy and as if it's simple, and I don't think I've seen a good example. You know, I haven't been here for a long time, only 40 years or so, but I don't think I've seen a great example of policy, research, practice, and there's a big move to knowledge translation and exchange. There's more innovation needed there, I think. The other thing is these things need to be grounded, and I think the Western Alliance in particular is to be congratulated for pushing this model. This is not expert-led external stuff. This is people working with and in communities to get this right where people spend their time and where they live. The other two things I'd like to say is that this innovation needs to happen much faster. It's not happening anywhere near fast enough for us, and industry's way ahead of us. Between two Twitter feeds, one about, big data is really important, we should use it. Below that is another tweet that says, this is a fantastic symposium, aren't we doing a wonderful job? In between those two tweets is something about Legoland. Now, Legoland Australia was announced yesterday or the day before. There's already a KFC Lego village that's got a video with the Legoland sign behind it saying KFC and Legoland together we are awesome. Now that's what we're fighting, and we're going to lose that battle if we're not a whole bunch more nimble than we are now, and if we don't get angry about it and mobilise. That's the truth of the matter. And all of these tools and techniques are useful to do that, but how do we use this data for advocacy and for engagement? So the big questions for me is, how do we use this information to generate and sustain change? I think that's critical. How do we use it so that we're nimble? We can't wait 3 years to find out something didn't work and then say, well, we have a hypothesis about why it didn't work, but that'll take another 3 years and another grant. I think this is about small communities. I think that's why I think the Western Alliance is important, why I think this initiative is important, is these chronic disease problems are going to turn around where people are well connected. In a place like the Southern Grampians, the leadership of the town and the people who have authority to make change are the same people. In Whittlesea or a large city, that's not the case. To demonstrate that we can do this and do it well, we need a community that's prepared to act and cares and is small enough to be able to work together. And then finally, I think a key point is, how do we make these things sustainable? We've all suffered from the feast and famine approach to funding, where external ring-fence funding for a program comes along and then it goes, and we were supposed to evaluate and we didn't, and we start again. How do we do what we do within the existing remit and the existing capacity to the best of the evidence base? And that's the big challenge I think that we've all got to meet. So that would be my summary.
So this is going to be a slightly historical perspective, but I did move to Deakin in late 2006 to start this new medical school, and it's dawned on me over the next sort of 12 to 18 months that there are a whole range of issues relating to rural and regional health that I was completely oblivious to before I arrived. And one of the reasons that I think I was oblivious to it was because I wasn't actually looking at it with a rural and regional perspective. But there were clearly some major health issues, there were some major workforce issues, which is why the medical school was set up in the first place. And there was a relatively limited research capacity to address them, and I think a relatively limited understanding of how we might go about it. And it seemed to me that we needed our own approach to try and address this area. And it needed to be an approach that was primarily based, I thought, around translational research. Now, that was the downside, and I used to get a little bit depressed about it at times, but it also struck me that there were a whole lot of opportunities. I missed David Asbridge's talk this morning, but I think he covered some of this. We've got a fantastic geographical opportunity with the range of urban and small regional and rural populations that we've got. It's if you like the ideal area for natural and other types of experiments. We've got the mix of Geelong, other regional cities, and the rural areas. We, in a way that you just don't see in metropolitan Melbourne, have an engaged healthcare community, and that's not just within the hospital settings, it's also particularly within primary care, and I think a relationship between primary care and secondary and tertiary care that is just very difficult to replicate in town. And we've also got universities that are actually interested in this problem and have some people who have the relevant skills. So, and part of that relevant skills, of course, is just what these other folks have been talking about now, which is an approach to data and people with the skills to work with data, both within the unis, but particularly within the health services and within the primary care network. So the idea of an academic health science centre became increasingly an obvious thing to do, and there was a number of us who've been talking about this for a long, long time, and it's incredibly pleasing to be sitting up here today at a meeting which is in Western Victoria, and we've actually had to stop the registrations because we didn't have enough space for the number of people who wanted to come to it. So we've really come a very long way. That allows us to address the sort of issues that I've rather inarticulately put into the program here that have been much better expressed by the speakers today. But I think we've made real progress along the way of answering some of those questions. But there are a number of issues as we grow that are, and I think Helen referred to this in some ways, that we need to be careful at an organisational and administrative level, and I just wanted to say a little bit about that. We're one of 3 academic health science centres that's been set up in Victoria. The other 2 are much bigger than us and they're much different to us. So Monash Partners centred around the Faculty of Health at Monash, and another group centred around the Faculty of Health at Melbourne. I was at a meeting, a ministerial a round table a month ago, when someone stood up and said, it's really important if the government wants to do something about research that it supports the 2 Victorian Academic Health Science Centres, and I had great pleasure in front of the Minister and Frank Maguire standing up and saying, well, actually there's 3 and ours is different, and I think that difference is actually quite important. It would be crazy for us to be trying to compete with Melbourne, with the sort of things that WeHi does, or with Monash with the synchrotron and the sort of things that the Baker does. We need to find a niche. And I think we've kind of evolved towards that niche, and what you've heard today, I think, is a very good sample of where we need to be. So it's about prevention, it's about health service planning, it's about the interaction between primary and secondary care, it's about addressing rural and regional issues, it's about health service and health systems research. So I think it's important that we continue to evolve that niche and use the expertise that we've got. I think it's important that, from a governance point of view, that I finish soon, and that we make sure that all the partners are getting something out of this. It needs to be a win-win for all the partners who are involved, health services and public and private. But I'm absolutely delighted with the way it's going so far, and for a non-researcher, that's probably far too much.
I've just put a few slides together to make a point, and I'm looking at it from a rural point of view. So the first thing I want to say if we can get to the next slide, is that we're all familiar with living in rural areas come with significant disadvantages with regard to shorter lives, higher levels of illness and disease, and risk factors in this regard, and not to have the same opportunities for good health than those living in the major cities. So the key challenges then, if we want to meet the needs of rural people, that's a bit too far, would be to maximize the services that's rendered in local areas. So we need to develop ample clinical pathways to refer those services that cannot be provided at local communities or in local communities to specialized health services. And a key thing here is to develop partnerships and close collaboration between rural, regional, and tertiary and academic health services. So we've heard today a lot about the arthritis, specifically osteoarthritis, and I found this slide on the Australian Institute of Health and Welfare website, where they found that there's statistical significant difference between people living in rural and remote areas in terms of the standard prevalence ratio for asthma, bronchitis, and arthritis. So to take that as a point, if you look at the next slide, the rate of osteoarthritis, and this is from Arthritis Map website. If you look at the rate of osteoarthritis per 100 people in the population, you can see that there's a clear distribution there on this kind of heat map. And if you now further superimpose the location of orthopedic surgeons there, you can clearly see that there's a vast discrepancy there. The majority of them are in the Melbourne area. And so this might also talk to the distribution that you've shown earlier in terms of the knee and hip replacements. If you look at the 5 and the 4 and the 3 there in the top parts, and the 6 in Geelong and the 3 in Warrnambool. The 1 there is in Stawell, can you believe it? So this is definitely a discrepancy. So if we take then orthopedic surgery as an example and look at the about just over 2,700 cases that in the year 2013 and 14 was done from the southwest of Victoria, almost half of these cases were done outside this area. And you can see there on the pie chart the distribution of the hospitals that actually provided that surgery. Whereas in our region, in the southwest, we have the capability of actually doing these services. So a lot more of those patients could have been helped locally. So if we then want to meet the need of our rural people, we have to provide those services close at home, but that doesn't mean telehealth services. It could mean telehealth services in some service modalities, and I've seen wonderful examples in the fields of psychiatry. We've got a lot of other fields where telehealth is a very good support service or supplementary to face-to-face consultations, but it cannot replace face-to-face consultations and services totally. We have to develop new relationships across existing boundaries, and I think there's a couple of good examples in the making in this region that we are busy developing. The key thing here is service coordination, and that's not always easy. So if we want to really meet the need of our people, and as researchers, we need to really listen to what those needs are. We need to make them part of the need development. And if we want to support sub-regional health services, you have to make sure that they retain their capacity for rendering acute specialist, emergency, ICU services, and also the allied health and the support services that goes along with that. So to denigrate the service mix will limit the capacity of agencies to attract other specialities. And if we are going to create further capacity and enhance the service mix, we're really going to achieve service innovation.